that we use in our clinic, I will give a little brief introduction about face masks, some evidence behind the skeletal anchorage methods that are most commonly used, and then I'll go into the appliances that we use at our clinic. So do we need skeletal anchorage for all class 3 patients? What about just face mask? What is it capable of? As you all know, the ideal time to start face mask treatment is before the age of 10 years, or in the prepubertal stages. Treatment takes usually about 12 to 15 months, and then the outcomes we have for maxilla varies between 1 to 3 degrees. Now this number is important because when you look at all the other studies, the changes in SNA usually stay within that range. And what about long term? So there's variability in the short-term results, and in the long term, when they followed up these patients, they saw that there was again some variable response. About 2/3 to 3/4 of the patients still maintained their correction, but the rest of the patients actually needed jaw surgery. The variable response is related to multiple factors. Some of them are related to genetic background, and some of them are more patient-related, and we can manage those, such as anchorage or the compliance of the patient. Because we have to start patients' treatment at a very young age, a lot of them are in early mixed dentition, so they have exfoliating deciduous teeth, and the adult teeth that are coming through, they still have roots developing. Which means when we apply forces onto the dental structures to get a maxillary response, we get mostly dental side effects. So that causes an increase in crowding, in the canine region especially, or you have the mesialization of the whole maxillary dentition. And that in turn reduces the skeletal outcome. So obviously, what can we do to increase our anchorage? We use skeletal anchor devices. And in today's lecture, I'm only going to be talking about the most commonly used ones because we have other lectures that will also talk about their point of view. So the first one that I would like to mention to you is the BAMP, bone anchored maxillary protraction, that was introduced by Hugo de Klerk. It has 2 maxillary anchor plates and 2 mandibular anchor plates, and class 3 elastics are used full time. For these anchor plates to be placed, obviously the patients will have to undergo general anesthesia, and for them to be removed, again, they have to undergo general anesthesia. And for them to be placed, the patients have to be over a certain age. Their lower mandibular canines would have to be erupted, and in the maxilla, the cortical bone thickness has to be a certain thickness. Otherwise, the skeletal anchor plates fail. So the patients have to be minimum at the age of 11 for this method to be able to use. When they looked at the maxillary changes this system provides in comparison to face mask treatment, the initial studies showed that the maxillary advancement was about 2.3 millimeters larger compared to face mask. And because it was purely bone-borne, you didn't have the side effect of vertical increase, and you didn't have the dental side effects. And when they looked at the changes in the mandible, they also saw that there was less chin prominence from the elastics that was applied to the mandible. And if the patient had asymmetry, they also trialed using differential elastic forces on the right and left sides, and they saw that that actually improved the asymmetry of the mandible as well. Later on, multiple studies followed. They also looked at what happened in the maxilla in 3-dimensional plane using cone beam CT superimposition. And when they looked at these patients, the patients were at the mean age of 11. They had about 1 year of treatment with BAMP system. When they looked at them individually, if you look at the percentages, in the middle row, you can see half of the patients had about 2 to 3 millimeters of maxillary advancement. Up the top, about 1/3 of the patients had 4 to 5 millimeters of change, but if you look at the bottom, about 1/5 of the patients actually had very minimal change, and they had to undergo general anesthesia for this method to be applied. So again, this technique is also providing us with variable response, so you have to be wary of that. There are, again, several reasons that could be attributed to this. It could be patient compliance. It could be actually the skeletal age the patient is at. Their zygomaticomaxillosutural maturation would also have an impact. The other most commonly used technique is the hybrid hierarch system that was introduced by Dr. Benedict Wilmes. The advantage of this system over BAMP system is there's no need to do general anesthesia. This can be placed in the chair. And the treatment can start much earlier. You don't have to wait like in BAMP treatment for the canines to erupt or for cortical bone thickness. Because as the anterior palate is used, there's enough bone thickness there and the patients can start treatment at a very young age. This system also prevents maxillary dental changes and it also helps you to create space. The initial studies that were done looking at the effects of these studies, they were two. One was in a very young age group, not very young, ideal age group I should say, before 10 years of age. Another study looked at the changes that happened after 11 years of age. So in both studies, if you have a look at the changes that happened in the maxilla, again, the change is about 2 degrees. The one in the older age group, as you can see, it was a little bit more. This group of patients also had ultramic, the alternating expansion and contraction to disarticulate their sutures a little bit more. What's also more striking is the treatment duration. If you have a look at the treatment duration, with face mask, we said it takes about a year. With this system, the treatment results were seen after even 4 months in the 2018 MINO study. Then another study was done by Peter Nan et al. In that study, they compared the effects of hybrid hyrax with RME face mask treatment. So the hybrid hyrax patients also had face mask. When they looked at the skeletal changes, however, compared it between the groups, they saw that there was no difference between the groups. Both groups had improvement, but there was no difference between the two groups. The reason for that could be, again, compliance reasons or because of the age. The patients were before 10 years of age. So it may or may not mean that at that age group, you actually don't need TADs because the sutures are maybe not too interdigitated anyway. Again, we won't know because we don't know the compliance level of the patients. However, they pointed out, even though the skeletal outcome was not different, there was reduced side effects. So there was reduced vertical changes in the hybrid hyrax group, and there was reduced maxillary mesialization. Now, I would like to show you a patient that we treated at our clinic at Sydney University. As you can see, this patient was a very significant class 3. When we took a PA radiograph of his incisors, we saw that even before treatment, his centrals had resorption, so they were short. So we didn't want to apply any forces on those incisors, so we chose to do the hybrid hyrax technique for this patient. In addition to using the hybrid hyrax, we also wanted to apply full-time forces. So for daytime, we gave the patient class 3 elastics and an Essex retainer, and we did the ultramic protocol. We did expansion for about 8.5 weeks. We finished with a little bit of expansion because he had, and we applied about 100 grams of class 3 elastics during the day and 500 grams of face mask force at night. So this is after 16 months of treatment. You can see that his dental malocclusion was solved, but also his facial profile changed significantly. Then he went on to full fixed appliances. You can see that he's still maybe a little bit class 3, but overall the facial changes are quite significant, and intraorally he also now has class 1 relationship. What was also very pleasing was when we did the PACS again at the end of treatment, we didn't see increased root resorption, so that was a very good outcome for the patient. And I brought the patient back 4 years later, to check how he was going. When he was coming through the door, he was so tall, so I was so worried that he would have gone into an anterior crossbite again. But looking at his dentition, it's still all right. He wasn't wearing any retainers. There's still some midline shift and a little bit of crowding in the mandible, but overall his facial changes were maintained. If anything, it got a little bit better, so he was a good grower. So the second challenge we have, in addition to encourage, is patient cooperation, as I mentioned earlier. Even though the patients are asked to use their face mask at least 14 hours a day, when those patients were assessed by using sensors in their face masks, it was seen that the patients were actually wearing them only 10 to 11 hours a day. And if you look at YouTube, there are so many videos about how horrible face mask is and how they can't do anything. They can't have sleepovers, they can't eat, drink, complaining, getting 4,000 views on how horrible face mask is. So what can be done? If we take away the extraoral appliance, like in a technique with BAMP, it was proposed that maybe the compliance would be better. An alternative to BAMP treatment, Hugo de Klerk's treatment, is proposed by Dr. Benedict Wilmes again. In this system, the mental plate system, the good thing is you don't have to wait for the lower canines to erupt. As you can see, the anchor plates are placed apical to the 4 lower incisors. So even if the canines aren't erupted, these patients could still start treatment. Obviously, there's still a GA need, but at least it's less invasive. So when they compared their outcomes with mental plate on patients undergoing face mask treatment, Wilman et al. Saw that the maxilla moved forwards similarly in both groups. So there was again no difference between using face mask or mental plate. However, again, let's look at the age group of these patients. The face mask group was quite young. The mental plate group was a little bit older, but they are still all younger than 10 years of age. So that may be one of the reasons why there wasn't a significant difference. If you have patients, however, young or a little bit older, if they don't wear a face mask, this is still a very good alternative. So you can start treatment at an early age in patients that are not compliant to face mask. I don't know if you've seen Dr. Nur Taraf present before. He's an excellent lecturer and he practices a lot with tags. And he did a PhD at our university a couple of years ago. One of his topics was looking at the effects of hybrid hyrax and a slightly modified mental plate. So if you look at that cone beam image, you can see again the modification is using trauma plates. So 2 L-shaped trauma plates were placed by the surgeon, again apical to the lower incisors, and in the maxilla, hybrid hyrax was used with class 3 elastics. So there was no face mask in these patients. And we wanted to compare the results with regular RME face mask patients, and we got the sample from Turkey from Professor Ayşe Altu. So looking at the outcomes, overall treatment took a little bit longer with hybrid hyrax mental plate group. And the reason for that is when you advance the maxilla with these type of skeletal anchorage appliances, because you don't get dental side effects, if you're looking at dental changes to stop treatment, the treatment actually takes a little bit longer, but their face improves even more. So face mask treatment was about 12 months. Looking at the outcomes, as you can see in the modified mental plate group, the change in SNA angle was almost 4 times more than the face mask group. And incisor changes, as expected in the hybrid hyrax group, there was not any significant change, but in the RME face mask group, there was a little mesialization. So this is one of the patients that was treated as part of that study at Noor's practice. The middle row shows the patient after 7 months, and the bottom row shows the patient after 14 months. And looking at the profile, you can see a very significant improvement. So that was the other types of appliances that are used, and now I'll talk a little bit about the appliances that we mostly use at our clinic at university. The first study that we did was actually completed in 2012, but it took us a while to publish this study. In this study, what we did was we used again the benefit system. So in the maxilla, the patients had hybrid hyrax with a bonded expander. In the mandible, we had lower lingual arch for the use of class 3 elastics. But we also wanted to minimize the dental side effects in the mandible. So we used 2 mini implants between the lower laterals and canines. And the patients were asked to use 400 grams of elastics. Again, we got the patients to do ultramic because they were a little bit older and we were using TADs in the maxilla. So they did ultramic for about 8 to 9 weeks, depending on whether they needed to finish an expansion or constriction. So this is one of the patients that was part of that study. You can see he had a significant improvement in his profile. He also had a functional shift, so that helped to get us there a little bit quicker, probably because he was a very significant class 3. So the patients had ultramic for 9 weeks, and when they finished ultramic, then they started using the class 3 elastics or 400 grams. And it took us a very short time to get there after that. It took us about 9 weeks to get the class 3 correction, which is quite striking. And again, looking at the outcome, you remember the number 1, 2, 3, 4 face mask. In this sample, with no face mask and just about 9 weeks of protraction forces following ultramic, we got a very similar outcome in SNA. It was almost 2 degrees. It's not, groundbreaking, but it's still a good outcome. It's at least as good as RME face mask. Because the treatment was quite short, we were a bit worried that these patients won't be stable, so we brought them back 4 years later, and then we looked at the changes again. And this was published later on. So when we looked at the changes in SNA angle, as expected at that age group, the SNA didn't change all that much. There was some rebound of mandibular growth, so we lost a little bit of the A and B angle. There was 1 degree of reduction. The upper incisors proclined a little bit during full fixed appliance treatment, and the lower incisor change was not significant. So again, this was a good outcome, we thought. And only 1 patient out of the initial sample didn't manage to stay corrected, but we still included their data in this analysis. So this is that patient that I showed you earlier when he came back for his control. Occlusion-wise, intraorally, it's not that great, but looking at his profile, the change is still maintained. So I'll show you one case that we treated using this method. A girl that was a very significant class 3. Intraorally, she has a lot of crowding, but when we looked at her OPG, it was even more sad because she had a lot of other problems. Looking at the cone beam section, you can see that she also had impacted 2.5, 4.6, and 4.7, and the 1.3 was quite bilacerated. So we used the same method for this patient. We actually wanted her to use face mask at night. So that's why the appliance has the face mask hooked, but she just never used it. So in the maxilla, we used the hybrid hyrax. In the mandible, we again used the mini implant supported lower lingual arch system with class 3 elastics. So this is her after 8 months of treatment, again just with class 3 elastics, and we extracted the 1.3 and the 2.5 in the maxilla. Before and after, this is after 26 months of full fixed appliances. As you can see, her profile improved significantly. It maintained, and intraorally now she looks good. We probably could have done a bit more expansion on the upper right-hand side. Again, before and after, and this is her 2 years later. She again was one of the patients that stopped using her retainers during COVID because it broke and she was never able to get in touch with us. Looking at the 4.7, the space opened up a little bit there. We probably should have done a fixed retainer there, but the class 3 correction itself was maintained, which is quite good. And the final appliance that I'll talk to you about is our least invasive one, I should say. In this one, we again use hybrid hyrax in the maxilla, but in the mandible, we just use a lower lingual arch and class 3 elastics. There are, of course, other versions of this in the literature, but this is the one that we like using. Again, we do ultramic for our patients. The main difference is in the mandible, because we do not have mini implants, we use light forces. It was only 125 to 250 grams of class 3 elastics for these patients. And again, we compared it to an RME face mask group, and the patient's mean age was 12. So looking at the treatment duration, it was much shorter than the RME face mask treatment because we had some dental changes too. It was a little bit easier to get there. Looking at the 2-group comparison, it was not significant. First we were a bit sad, but then thinking about it, with no face mask and just about 200 grams of class 3 elastics in patients that were 12, then we thought this is a pretty good outcome. Dentally, in the RME face mask group, obviously we had some mesialization, and in the mandible, in the class 3 elastic group, we had some distal tipping of the mandibular teeth. We don't have the long-term data for these patients, it's still in progress. So this is one of the patients that we treated with this method, only class 3 elastics and lower lingual arch, and it took us about 8 months to get there. And this is her before and after. Because she had the hybrid hyrax, she was missing her 1.5, Hybrid Hyrax appliance is quite versatile, so we changed the abutments and changed it into a mesial slider once we were finished with class 3 correction. On the right-hand side, you can see the molar relationship is class 2. That's because she was missing the 1-5. And the final case that I'll show you, again, was treated with the same appliance. But the reason I want to show you this one is because we had a little disaster here. So this patient was 13, a little bit more severe class 3, and when we started treating this patient, the postgrad and I forgot to put the occlusal rest on the lower 7s. If you're not going to use mini implants in the mandible, that class 3 elastic works like a cantilever. So when the patient came, and also I can't use this laser pointer, sorry. If you look at the left-hand side occlusion, there's a gap. So I don't know why it didn't happen on the right-hand side, because we didn't have the occlusal rests. If you look at the image at the bottom right-hand side, the 3-4 has extruded significantly. So when I saw this, I was like, oh my goodness, what happened there? But we recovered, so don't forget to put occlusal rests. So this is before and after 12 months. And this is in after full fixed appliances. The occlusion is nice. Some of the changes, facial changes in this patient, it relapsed a little bit because he was more class 3 and 13 when he started. So finally, take-home messages. How are we going to decide what type of appliance to use? If your patient is young, younger than 10, you can still give it a try with RME face mask. But if your patient is older and at the pubertal stage, it may help the patients if you combine your treatment with TADS and with Ultramec. And what we like doing at the moment is we like using continuous forces. So we just don't rely on just face mask or class 3 elastics. We actually tell the patient, ideally you should use a face mask when you sleep, and when you don't have the face mask, put the class 3 elastics on. But we're collecting data on that. I don't know if it's going to be any more beneficial. So if you have a patient that's very sporty, likes to go out, doesn't come home, if they're not compliant with face mask, TAD-supported appliances are at least as effective as face mask, even in older children, which is good. But you still need compliance with class 3 elastics, so if you have one of these children, it's going to be a disaster. Again, we need long-term data for these appliances. And these are the things you also need to consider. You need GA for BAMP and a good surgeon, and there's extra cost involved. With the hybrid Hyrax, it's cheaper. You can just do it in the dental chair yourselves, but you still need a compliant patient to be able to go through the procedure. And then finally, the dental structures or skeletal structures that may help you to make a decision. If you need vertical control, and if you need to minimize the dental side effects, and if you need to open space, you may want to use BAMP or hybrid Hyrax mental plate combination. If you want to correct the asymmetry, and if you want to maintain your correction and use retention class 3 elastics, you may need to use a BAMP appliance, but there's no long-term data on that, so be wary about that. If your patient needs expansion, and if you want to start earlier, and if you want something a little bit less invasive, again, hybrid Hyrax with either our lower lingual arch appliances or the mental plate could be the appliance to use. And finally, if you also would like to do simultaneous space opening during phase 1, hybrid Hyrax appliance also lets you do that. So you can add the part that distalizes, again, that was introduced by Dr. Wilmes, at the same time as doing your class 3 correction. And this is probably done by Simon Graf, maybe. And if you need to do space closure for congenitally missing teeth, again, you can just change the abutment of your hybrid Hyrax at phase 2 and use it as a mesial slider. Thank you very much.